Welcome to the lecture on management of severe pre-eclampsia and eclampsia. And we are talking about this because we all know that this is the main cause of maternal death worldwide. I'm going to refresh your memory in recognizing pre-eclampsia and eclampsia and paying particular attention in the management of when and how we use parenteral anticonvulsant, when and how we use antihypertensive. We maintain a strict fluid balance and then monitor the treatment. After this, we really need to concentrate on what are our choices about delivery, because delivery is the treatment in this condition. And last but not the least, paying attention on anesthesia for cesarean section, because 2/3 of the women in this suffering with this condition are delivered by cesarean section. We define hypertension in pregnancy in two broad categories: chronic hypertension and gestational hypertension. Chronic hypertension is when the mother's blood pressure is raised at booking or before 20 weeks, which is usually due to a maternal pre-existing disease like essential hypertension, renal disease, etc. But be mindful that due to the effects of the pregnancy, it may be masked. So if the try to be vigilant in every visit. But this kind of hypertension is always evident before 20 weeks. If we find a raised blood pressure of more than 140/90 millimeter of mercury on two consecutive readings after 20 weeks of gestation, it is called gestational hypertension because it is related to pregnancy. We also call it pregnancy-induced hypertension. This one is divided into three categories: mild hypertension, when the blood pressure is above 140/90 but below 150/100, moderate hypertension, when it is above 150/100 but below 160/110, and severe hypertension, when the blood pressure is more than 160/110 millimeter mercury. How do we define preeclampsia in pregnancy? The one-line summary is when gestational hypertension is associated with significant proteinuria, we confirm preeclampsia or define preeclampsia. What is significant proteinuria? Significant proteinuria is when there is 2 pluses or more protein on urine analysis on dipsticks, or more than 300 milligram protein in 24 hours protein, or a PCR ratio of more than 30 if that's available. We need to know what is severe preeclampsia. When the mother's blood pressure is more than 160/110 millimeter mercury with significant proteinuria and she has one or more symptoms or signs of severe preeclampsia, which are headache, visual disturbances, epigastric pain, or increased reflexes, or clonus present, or reduced urinary output less than 400 mils in 24 hours, then we diagnose severe preeclampsia. And obviously, any convulsion in pregnancy associated with preeclampsia is diagnosed as eclampsia, even if the woman is normotensive. The rule of thumb is that any woman who has a convulsion in pregnancy should be treated as eclampsia unless otherwise proven. What are the predisposing factors for preeclampsia? First, pregnancy, extreme of age, a long or short pregnancy interval, multiple pregnancy, obesity, or any family history of the mother or sisters having had preeclampsia or early onset heart disease, as well as mother's medical condition like diabetes, pre-existing hypertension, or any thrombophilic condition like anticardiolipin antibody syndrome. So these all predispose to development of preeclampsia. How can we prevent or reduce the risk of the mother? the key to the to any condition is diagnose it timely, diagnose it early, and antenatal care is the best screening test. In antenatal care, if we perform, and we should really perform, blood pressure and urine analysis, we can confirm preeclampsia very early. The third test is fundal height measurement for fetal growth after 24 weeks gestation. So we should really perform these three tests at every antenatal contact. If the woman is screened positive, that is, she has high blood pressure and proteinuria, then we must ask of all these symptoms to differentiate and grade it from mild to moderate disease to severe disease. Um, just a little point on measuring the blood pressure properly. The woman should be properly rested. If she has walked a long distance, she should be asked to take rest, and then we take the blood pressure. She should be sitting at 45-degree angle. The machine should be at the level of the patient's heart, like in the picture, and the proper cuff size should be used. A manual sphygmomanometer is preferred to automated machine, but if you have automated machine, its calibration should be validated. Use a stethoscope and phase 5 quart cough sound to detect diastolic blood pressure, which is actually disappearance of the quart cough sound. Other examinations and investigation are very important because preeclampsia is a multi-system disorder and it affects mothers' all systems. So to find out whether the neurological system is affected, we do patellar reflex, ankle clonus, and to see if the baby is affected, check the fetus for growth and heart rate. Additional investigations, which are an imperative part of the whole workup of diagnosis and the degree of disease, is renal function test in the form of urea and creatinine, liver enzymes, hematological system in the form of full blood count for platelets mainly, and clotting test. If you don't have lab facilities available, you can do a bedside test with 2 mils of intravenous blood in a test tube. Keep it warm between your hand and check it in 2 minutes. If the clotting is normal, the blood will clot. If the clotting is deranged, it will take 7 minutes to clot. We assume eclampsia if there is a fit in pregnancy unless otherwise proved, and until we stabilize the mother. After that, take a history and find out whether she has had epilepsy, or she had fever or chill and rigor, etc. But the main differentiating point between these conditions, between eclampsia, epilepsy, cerebral malaria, meningitis, hypoglycemia, or intracranial tumor, which may cause a fit, is these women would not have raised blood pressure or proteinuria, and then you can use additional tests to confirm it. The main principle of managing eclampsia is delivery. That is the only cure because the disease is in the placenta. But before we administer delivery, we need to stabilize the mother. And we have to be aware that it is a systemic disease. So therefore, even when we deliver the baby and the placenta, the disease does not really disappear immediately, and in fact worsens in first 48 hours. So with this in mind, we first manage a woman's airway so that she can get oxygen. Then we treat and prevent fit. We then reduce the blood pressure, keep a strict fluid balance, and we try to prevent complication by doing all these. We are committed to delivery once the woman has a eclamptic fit within 12 hours. Sometimes a woman may be brought to your facility first time with a fit and has had never raised blood pressure or proteinuria. If in this case, just be mindful, and even if the blood pressure is normal, catheterize the woman and do an urine analysis. If there is proteinuria, she is eclamptic. So, if a woman is brought to your facility who has had a fit or she's unconscious, the first thing we would do is call for help and then pay our attention to the basic ABC. Open the airway with chin lift and head tilt, and then maintain an open airway with girdle. Take the respiratory rate and apply oxygen. Then, to prevent regurgitation of the acidic gastric content, turn the woman in recovery position so that she does not aspirate her gastric fluid. And then we take the blood pressure and establish intravenous access to commence magnesium sulfate immediately. If you have time, you should really get a second IV access to take the bloods and open it with a very, very small dose of fluid. Keep it open with small dose of fluid. Magnesium sulfate is superior to any medicine, especially diazepam, in reducing, almost halving the risk of eclamptic fit in women with severe preeclampsia. But it is not treatment. It does not really prevent the progression of the condition, and it should not be used as antihypertensive because it does not reduce the blood pressure. We use the same dose of magnesium sulfate to treat eclampsia and preeclampsia, and once we have started magnesium sulfate, we are committed to delivery, even if the baby is not mature. So whatever the gestation, we are committed to delivery within 24 hours if it is severe preeclampsia and 12 hours if it is eclampsia. I've already said about the worsening of the condition in 48 hours. So, how do we start, or when do we start magnesium sulfate for treatment of severe preeclampsia and mainly to prevent eclampsia? I think that we have already defined severe preeclampsia and the conditions which are associated. So please go through this. High blood pressure of 160 by 110 with significant proteinuria, with one or more of these symptoms and signs, then you diagnose severe preeclampsia and start magnesium sulfate. So I'm not going to repeat, but magnesium sulfate is the drug of choice, proved by very, very good evidence. It's available in two concentrations, 20% for intravenous route and 50% for intramuscular route. When we start magnesium sulfate, we give it in two doses, the loading dose and maintenance dose. The loading dose is to start with intravenous 4 gram, 20% solution, slowly over 15 minutes while you watching the mother's respiration. And once you finished it, then start 10 gram, 5 gram of 50% solution intramuscular in each buttock with 1 ml of 2% lignocaine. Then after 4 hours, we administer the maintenance dose 5 gram intramuscularly in alternate buttocks. If you have the intravenous pump available, then you can use intravenous maintenance dose 1 gram per hour for 24 hours. Even if you don't have intravenous facilities available, please give intramuscular component of the loading dose before you transfer the woman to the right facility. The next slide, I would want you to keep it and take it from your lecture, and depending on your local guideline, use either intramuscular or intravenous or both in this way, and prepare it in this way. If the woman has a recurrence of convulsions, even after we have given magnesium sulfate, we can again give additional dose of magnesium sulfate 2 to 4 gram over 10 to 15 minutes, usually 2 gram if the woman is lighter, to prevent recurrence of fits, and dilute it always with normal saline, not lignocaine. Now we have stabilized, we have used magnesium sulfate, we really need to monitor the mother's vital sign every hour, and especially before patellar reflexes before next magnesium sulfate. So the vital signs are conscious level, pulse rate, blood pressure, respiratory rate, fetal heart rate, urinary output, and patellar reflexes and ankle clonus at least 4 hourly, but definitely before next dose of magnesium sulfate. These should be documented clearly. If we, how will we know that magnesium sulfate toxicity is developing? By observing three vital signs at least hourly, and these are respiratory rate between less than 10 to 16, and you follow your local guideline, or urinary output less than 100 ml in 4 hours, or absent knee jerk. If you think that the toxicity is developing, in that case, you can use the antidote calcium gluconate. Remember, 10, 10, 10, 10 mils of 10% over 10 minutes. But if there is no toxicity, you just withhold the next dose of magnesium sulfate, and once her breathing is normal and the urine output is more than 100 mils in 4 hours, you do repeat the magnesium sulfate. Now coming to the reduction of blood pressure, when mother's blood pressure is less than 160 by 110, there is still risk of stroke and placental abruption. So we should use the safest drugs are methyl dopa, nifedipine, and labetalol, and aim to reduce the systolic blood pressure to less than 150, and the diastolic to less than 100. So less than 150 by 100. When the mother has severe hypertension, that is blood pressure equal or more than 160 by 110 millimeter of mercury, there is an extremely increased risk of intracerebral hemorrhage, and we should try to reduce the blood pressure with hydralazine, labetalol, or nifedipine. A main caution is to avoid sudden reduction in blood pressure and aim to reduce the blood pressure by 10 to 20 millimeter mercury every 10 to 20 minutes, and keep it between 140 to 150 by 90 to 100 millimeter mercury. Now, why we have been putting so much emphasis on fluid management, and we have to aim to keep the woman dry, because in severe and pre-eclampsia and eclampsia, the capillaries leak the fluid into the third compartment in between the tissue, under the skin, in the pulmonary area, in the lungs, and in the brain, causing pulmonary edema and cerebral edema. So if we give lots of fluid to the woman, it will simply leak to and cause pulmonary edema and cerebral edema. Therefore, we restrict the fluid to 1 ml per kg per hour, which is usually 80 mils per hour. You could consider 40 ml plus the previous hour's urine output, which will be usually 80 to 100 ml, but not more than 100 ml. So basically stick to 80 ml per hour. Also closely monitor the input and output, and we have to put a urinary catheter to monitor output. If there is hemorrhage, then a small amount of fluid can be added, but it should be individualized and strictly keep 80 ml per hour generally. General care is important, one-to-one care to all eclamptic patients, because they are not paralyzed and they can just move, but they are still unconscious. So they can have a fit as well. So therefore, they should be nursed in recovery position, and they should be changed every 2 hours to avoid pressure sores. Delivery is the treatment or cure. So we have stabilized the mother now. Now we have to think about what are our choices of delivery. Either can we do a vaginal delivery or cesarean section. This will depend on what is the duration of the pregnancy, is there any fetal distress, or is there any maternal destabilization, any other obstetric indication like previous 3 cesarean section, and if the cervix is favorable. So if the woman is, say, 39 weeks pregnant and she is 4 centimeter dilated and she had an eclamptic fit, you have 12 hours and you could really augment the delivery. For pain relief, please consider opioids or lumbar epidural analgesia if the platelet count is more than 100 million per liter. Cesarean section when the woman is like very early gestation, or she is having recurrent fit, or there is evidence of fetal distress, or the cervix is completely unfavorable. So we have to take all these in consideration to decide the route of delivery. I think that first 24 to 48 hours the condition may deteriorate, so you have to keep strict vigilance. Magnesium sulfate should be continued for 24 hours after delivery or after the last fit, and you do not need to tail it off, you have to stop it straight away. 4 out of 10 eclamptic fits do occur in postpartum period, so be mindful. Monitor the blood pressure and stabilize it, and you can improve the fluid input or take the restriction away when the diuresis starts happening, which is usually between 36 to 48 hours. Please do not be in a hurry to discharge woman, and it's a good idea to keep her for 4 to 5 days. I'm just adding a note that edema is present in 80% of normal pregnancies, and it is not really a sign of pre-eclampsia. There is also no evidence to suggest that if we give a low salt diet to a mother, then it will reduce edema or reduce the development of pre-eclampsia. Also, furosemide should not be used to either reduce edema or improve urinary output. The furosemide use is only justified to treat pulmonary edema. Breastfeeding is very, very safe in pregnancy, and a very small amount is secreted in milk. So please encourage the mother to breastfeed. A quick recap now. Pre-eclampsia is a complex multi-system disorder which affects all the systems of the mother, especially causing hypertension, affects the kidney, the liver, the neurological system, and the hematological system and fetus. So always look for the signs and symptoms and investigate all these symptoms, all these systems. Magnesium sulfate is the drug of choice to control or prevent fit, and once we have started magnesium sulfate, we are committed to delivery. Do not overload the woman because that will cause pulmonary edema or increase cerebral edema. Keep them dry, and the deterioration can happen postnatally, or it can start first time in the postnatal period. Thank you very much for listening, and I hope that this lecture helps you safely manage the mothers with pre-eclampsia and eclampsia.